Good morning, everybody. It's a pleasure to me to be here with Professor Manuel Montero Dasso. Manuel is a friend, a colleague, a geriatrician, and he nowadays is a professor of the Department of Medicine, Epidemiology and Biostatistics, director of Gait and Brain Lab in Parwood Institute, Division of Geriatric Medicine, faculty scholar at the University of Western Ontario, and a scientist Lawson Research Health Institute too, and is the vice president of the Canadian Gerontological and Geriatrics Society. For me, it's a pleasure to present Manuel. As I said, he will talk to all of us about falls and some important remarks about the falls global guidelines that he and a very interesting group are performing nowadays coming from a lot of countries in the world. And of course, in our concern, from Manuel and to me too, it's a pleasure to honor in these conferences to our professor in geriatrics, Professor Roberto Kaplan, that was one of the key persons in our professional life. So, Manuel, please go ahead. Thank you.
Thank you very much, Professor Howdy, for your kind introduction. And thank you everyone for attending to this lecture. This lecture is entitled in honor of Professor Roberto Kaplan, one of the pioneers of geriatric medicine in Argentina and Latin America. And today I will speak about falls and cognition. I will review the evidence, assumptions, and therapeutic options. Here I have a picture with my mentor in Argentina, Professor Roberto Kaplan. Unfortunately, now is retired due to cognitive impairment and dementia, but he has been key in developing all our training and also to foster several generations of the geriatrician in Argentina. So I would like to dedicate this talk to my mentor and friend, Professor Roberto Kaplan. I don't have anything to disclose, and the objectives today of my talk are going to go to review the role of cognitive deficits in fall risk in older adults, to address assumptions and how we approach current fall prevention management, and to appraise the role of cognitive treatment as a strategy to reduce risk of falls in older people. What is the connection about falls and cognition? Well, this picture is depicting Desmond Morris. Desmond Morris was a zoologist and ethologist at Oxford University, and he wrote a lovely book, The Naked Ape, that Professor Roberto Kaplan gave me when I was a young general internist in the Italian hospital, and I was considering the idea to pursue a specialization in geriatric medicine. And when Roberto shared this book to me, he told me, focus here, how human development is key to understand how, when we get older, our cognition and mobility decline. And in one of the first chapters, Desmond Morris, in this book, had the following quote. One is speaking about the ancient ape before evolving to human beings. And is that ancient ape was able to keep his body in the upright position, to move his hands in one way and their feet in another, and to keep improving his brain and use his mind as best as possible. He stood a chance of success. Basically, in the evolution, human beings not necessarily were created to be the dominant species. Particularly, an important achievement was the encephalization process. And it seemed in order to develop this brain, bipedalism, so to keep the upright position, was key. In other words, there is a phylogenetic gait and cognition association. The process of bipedalism took at least 5 million years. And in this process, at the end, we develop also bigger brains that we call encephalization. So bipedalism, it seems, is closely related to encephalization. Anthropological studies have shown that for the early hominid transition to the modern hominid, I think was around the Homo habilis, in where our brain size was very similar to the ancient apes. But at that moment, before going to Homo erectus, the Asian hominid spent the majority of the time in 2 feet and has some modifications in order to walk all the time rather than to crawl. And with the development of this bipedalism, the size of the brain increased, double the size. And to reach, the new hominids like the Neanderthals and also sapiens, and the sapiens sapiens, our current species. So it seems in this period, almost 1.5 million years in evolution, the bipedalism was a necessary requisite to get bigger brain size. There is several explanations about that. Some simple explanation, okay, bipedalism, you are able to release your hands, become hunting, change your diet. Independently of the reason, there is several contentions. Today, all the anthropologists agree that bipedalism was a fundamental adaptation in order to get bigger brains in civilization, and it happened 1.5 years before that process. But also, it seems there is an ontogenetic relation on gait and cognition, particularly in the decline. So this process that happened in a species, in the human evolution, in one single individual can decline, because can be only 80 years in our mobility and our cognition decline, and the consequences are falls and fractures, but also cognitive impairment. In fact, when I want to describe what makes a person to look old, I think those for clinicians like myself that we see patients, older people, they have a slow mobility, particularly a slow walking speed or a slow gait. But importantly, they have like a low cognition or mentally slow. With our processing speed, our attention, or executive function is not as fast as we're younger. And more importantly, those two conditions that happen with aging and diseases associated with aging sometimes concur, happen both together in the same individual. In 2016, with my colleague, Professor David Hogan, we were chairing the false interest group of the Canadian Geriatric Society, and we tried to address which are the gaps in our understanding of fall management and prevention. And one of the topics that we highlight was cognition. We question ourselves, why are falls so common in the cognitive impaired? Why does fall prevention not work as good in this population like in the cognitively healthy population? Are we assuming facts? Are we missing a treatment component when we do those preventions? And we don't want to reinvent the wheel, because already one of the fathers of modern geriatric medicine, Bernard Isaacs, published in the 70s in Age and Aging, that unfortunately, cognitive impairment is an important cause for falls, and falls can be seen as a manifestation of brain failure. But Bernard Isaacs asked himself, can anything practical be done other than try to avoid obstacles or avoid polymedications to prevent falls in this population? Even he speculated the possibility of pharmacological treatment for fall prevention. And that was quite revolutionary. As you can imagine, at that moment, polymedications and medications were against fall prevention. In fact, in order to prevent fall, we want to take medications out or to reduce inappropriate medications. And also it's a current approach, but he allowed him to intellectually challenge himself and to speculate, can we test some medications improving cognition or processing speed to reduce the rate of falls in the cognitive impaired? And why we're treating this topic today in the Roberto Kaplan lecture? Well, because falls are quite prevalent in people with cognitive impairment, particularly people with dementia. It's double that you compare the incidence with people without dementia. But not only people with cognitive impairment and dementia have more falls, they have more risk of having an injury and a fracture after the falls for several reasons, probably because they have less, for example, defenses, reflexes, or they are more frail. And not only they have more injuries and fractures, but the functional outcomes after a fall deteriorate more quickly. They have less access to rehabilitation in some countries, and some systems very difficult to access to rehabilitation. They have higher prevalence to get it institutionalized or going to nursing home after a fall because they have dementia, and they have more mortality, higher mortality when compared to the cognitive healthy. So as you can see, it's not just the prevalence of falls and the incidence increase, but all these negative consequences are much more common in people with cognitive impairment dementia. And to make the matter worse, fall prevention is not successful in this population as is in the cognitive healthy or the cognitive non-impaired population. A typical meta-analysis, and this has been corroborated in new studies, was done by Oliver and published in the British Medical Journal in 2007, in where he analyzed all the multifactorial interventions, particularly in residential care, so nursing how to prevent falls. And you can see in this meta-analysis, there is a trend to prevent fall, probably around 8% prevention, but look at the confidence interval, they crossed the 1, so it was not significant. And still today, this is quite, I would say, expressing the evidence. It's very difficult to get very good, successful falls prevention in this population. And why? Well, there's a clear role of cognitive impairment in fall risk, but interesting 10 years ago, my former postdoctoral fellow, Dr. Susan Moore-Hunter, she wanted to put the number, she wanted to analyze, particularly in the community, which is the hazard ratio and the odds ratio. And in this meta-analysis, she found that being cognitively impaired increased your risk to have a fall and a serious injury almost 2.3, more than 2.3. So almost double, more than double. Importantly, if you analyze not only global cognition, but you look for domain, the domain of cognition that was more associated with future fall was poor performance executive function. Not only have a very low executive function, but also in some populations, some studies, it was found that participants being cognitively healthy, but with low performance in executive function compared with those with high performance, they suffer more falls and also more injury in the falls. And interestingly, the serious injury, as I say, was 2.3. And the variability across the study is very low. So it seems a very robust, strong meta-analysis. In fact, we conclude in the systematic review with Dr. Moore-Hunter that probably executive function should be assessed as part of the fall risk assessment. And just to show you one of the studies, this is a study run by Herman and the group of Jeffrey Hauser in Tel Aviv, in where they included 262 older adults that they followed for 2 years, and those people that were without cognitive impairment, but they did some neuropsychological testing, and they found that those with worse performance in the executive function, 50% may suffer a fall after 2 years, while those with better performance in executive function, only 21%. And that was true also for the second fall, for the time to second fall. So having lower performance under normal ranges, but lower performance in executive function, not only predict the first fall and the time to the first fall, but also is an important predictor of the second fall. And several studies have corroborated these findings since then, and today I would say is widely accepted. But how the cognitive deficits may increase risk of falls at early stages? What is the relationship between gait and cognition? Well, in a classical paper we published 10 years ago, we found that we tried to describe this relationship, and we analyzed the known relation about mobility impairment as an important predictor of falls and fractures, and cognitive impairment as an important predictor of dementia. Clinicians like ourselves, we found that before having those falls and fractures, we slow down our gait speed, slow gait speed. And before having dementia, we have some cognitive impairment that we can, I will say, qualify as mild cognitive impairment. Importantly, in our clinical practice, it's not uncommon when we receive in our hospital or clinic someone with falls and fractures, we make a new diagnosis of cognitive impairment dementia, and vice versa. When we meet someone with dementia, we can see they have previous history of falls and fractures that perhaps are unknown. So this relation here, I would say, is very well known for every clinician seeing older people. But something we speculate and we try to demonstrate in our research but other groups is that relationship between mobility problems and cognitive problems started much, much earlier than the 7 or 8 decades, perhaps in your 60s, in your 50s. Importantly, we found clear associations between how this slowing in mobility may predict more cognitive impairment and vice versa, how low cognition in some domains, like executive function, as I mentioned before, may predict falls and fractures. And this relation between slow gait and low cognition, again, is touched much earlier than when it's fully manifested as false fractures or dementia. So there is like a continuum here. And what is that? Because when I was in medical school in the 80s, I was taught in neurology that walking is automatic. We don't need our cortex or high cognitive process to walk. And that is because all those research in walking and the regulation of walking has been done in a model with the decorted cat. They put the animal in a treadmill, they cut the connection between the high cortex with the basal ganglia, and the cat keep walking because they found, some centers in the spine that call center part generators that maintain the rhythm and the pace in cats. But interestingly, in the late 90s, Lundin Olson from Scandinavia, she was working in a nursing home and she noticed that some people, some residents in the nursing homes, before going from the running room to the rehab gym, they need to stop to say hello to her, while others were able to walk and to say hello, good morning, Dr. Lundin Olson. And she was asking herself, why some of my clients or patients, they need to stop to speak to me and say good morning, while others are able to walk and talk at the same time? Is because some of them are more polite, the other ones? Well, she followed those patients and she found the following. In this graph, we see in the y-axis the proportion of people without falls at time 0, and we have a follow-up up to 6 months in the x-axis. And we can see those participants that were able to talk and walk at the same time in the dotted line, only 20% suffer a fall after 6 months. While those older adults in that residency, they were not able to talk and walk at the same time. They need to stop walking when talking. 80% suffer a fall. And he called this like a stop walking while talking test, and she compared with other tests, and the predicted value was 80% for a fall, and with the highest specificity, 90%. But when she went to analyze those participants, the majority of those, have some cognitive impairment, particularly 26 of them have dementia. So this is particularly true in those having cognitive impairment. And when she compared this test with other complex tests, but the POMA genetic test, she found that the predictive value specificity was much better. Anyway, this was a very seminal paper, a small sample, 1997. This Lundin Olson replicated in 100 participants, other studies have replicated that. And today, we do know the association between stop walking when talking as a cognitive interface as a risk of falls. But I think we can now say, yes, there is a relation between gait and cognition. And in fact, our patients often explain that fall when they become distracted, when they don't pay attention, they don't pay the high level of cognition like attention while walking, or when they need to switch attention or perform multiple tasks, like being in the kitchen or the bathroom. Importantly, which are the cognitive domains associated with falls? Well, as I said before, executive function is a classic domain, but several studies, and this is a very busy slide, but it's an excellent review published by the group of Morris and all the researchers in Newcastle, that show a clear correlation associated with global cognition and several impairments in domains of gait, like the speed, the variability, the rhythm, the asymmetry, and also the postural control. And of course, executive function is the most likely domain being involved, and this compares several studies. Green dots are studies that show associations. Red dots are studies that don't show this association, but you can see global cognition, executive function, attention are very, very well related with this speed, but also memory. There is some studies showing that memory, language, and processing speed are associated. So there are several domains. It is not only executive function that may be related to slowing gait, altering the pace, and increasing the variability or the asymmetry. In fact, I want to show a couple of videos. This patient of my clinic, this video was done in 2007. This is a gentleman with mild cognitive impairment. Unfortunately, he developed dementia, and 12 years later, he passed away. But at this moment, I was testing his gait while talking. Basically, I asked this gentleman to walk and do calculations, subtracting 7 by 100. So 100 minus 793, and so on. Here we see the single task walking. As you can see, when I ask this gentleman to walk, his walk, I would say, is almost normal. We can see the footprints detected by this computer-set gait mat. He has a good pace, good stride. It looks quite symmetric. Interesting excursion of the arms. No, I would say almost a normal gait. Again, when I asked this gentleman to walk and do those calculations doing the serial subtraction by 7, you can see in this video that the patient starts correctly, but later on slow down a little bit. In the middle, hesitate, make a short step, follow with a longer step. The excursion of the hand is not very well presented. And you can see that it's a clear asymmetry in the footprints. Although you can see this at naked eye. It's not easy to see all the time this variability at the naked eye. And now I'll put the two videos at the same time so you can compare both. And you can see this walking while talking is much slower. Here I finished the walking, you can compare the asymmetry. And in fact, if you compare the speed, just the normal usual gait was around 1.5 meters per second, good speed. The variability of the asymmetry was below 3%, while doing the serial calculation by 7s, the speed went down to almost 40%, one meter per second, and the variability increased by 13%. And this difference between the speed in the single task, while the speed and dual task gait, or when they are doing the walking and talking, we call the cost, the dual task cost. How much cost to our walking to get our brain distracted, or to get a stress activity in the brain. And there's a formula how to calculate this difference, and it seems this difference in this gender was at 30%. So there is a 30% reduction in the gait speed, or a 30% increase in the variability too. And how this works, this gait or dual task gait paradigm? Well, in single task, you activate the prefrontal cortex, the parietal lobe, and also the cerebellum. When you do calculations, you activate also some area of the parietal cortex and the prefrontal cortex. And it seems when you do both activities at the same time, you share resources. So some areas in the prefrontal cortex are important for the navigation or attention of walking are also important to do this calculation, as in the parietal lobe. And it seems when those areas, we don't have enough resources to share to do the switching attention, our gait may suffer, or our cognition, depending on the priority we do in the test, right? So in other words, when we walk without any stress in our brain, when we focus in walking, we don't get distracted, we don't count, you know, our automaticity is very high, the variability of the asymmetry is very low, the attentional load is minimum, we're not getting distracted, and the risk of falling is very low. However, when we get distracted or we try to do more than one thing at the same time, we move in this line to a higher attentional load, with our walking become less automatic because we need to watch where we're going, because our default network cannot focus on that because we're doing other activity, and the variability of the asymmetry increase, posing this patient or this individual at a higher risk of fall. And that was an explanation we tried to provide out of this. But in other words, we do know that dual task paradigm is not only important for research purposes, but also because the dual task paradigm reflects clearly activity of the daily living, because the majority of the activity of daily living involves doing two activities, sometimes three activities at the same time. So imagine being in the shower, trying to get a shower and to open a tap, or while cooking and getting a phone call, and so on. And importantly, the majority of the falls in all the people happen with injury, happen at home, and happen in places like the bedroom, the bathroom, the kitchen, where sometimes we do multitasking. In other words, walking is very cognitive demanding. So imagine when you try to cross Yonge Street here in Toronto, a very busy street, or when you want to do that in the winter, you need to be careful of not sleeping in the snow, or to try to avoid the cobblestone. Or imagine you to do while managing a device like a walker that can be cognitive challenge, when to press the brake in the walker and so on. So basically, walking is a cognitive demanding task. But how this gait cognition interaction increase the risk of falls? What's the issue about, for example, obstacle negotiation, gait variability, and so on? Well, my former postdoctoral fellow, Dr. Federico Faria, now is adjunct professor of medicine, he wanted, now he still wants, but he wanted this experiment to see how all of those were dealing with the obstacle negotiation. So when they face an obstacle, when they're walking, and how the steps and the pressure may vary. And he created this device, this apparatus that they put in the middle of this walkway. And you have people walking and you have an obstacle, and you record before the obstacle and after the obstacle. And he found the following. He found that when you walk in the unobstructed area, fallers and not fallers, so all the adults, same age, sex, but with history of falls, they do quite similar about the asymmetry of the variability of the gait. Fallers may have a little higher variability around 4. But that difference, how the gait variability increased, was much, much more marked when they need to negotiate with an obstacle. So not fallers, they try to overcome the obstacle, increasing the variability by 5%, but fallers, they become more hesitating. The asymmetry increased by almost 70%, and that difference was significant. And that happened not only in the step time variabilities, not only the timing, but also in the length. So that asymmetry is about distance and time, both of them. And you can understand that we do not high variability, put more instability with more asymmetric. So that can be a factor that people that cannot negotiate very well an obstacle may trip and fall. And he did the same, but now in people with cognitive impairment, particularly with mild cognitive impairment, which is a pre-dementia state. And he asked those people to deal with that obstacle, not only by walking, but also while doing dual tasking, while doing calculations like before. So in some point, it was a triple tasking activity, just the walking, dealing with the obstacle, plus talking, right? Triple tasking. And he found that there is, in the gait speed, for example, he couldn't find a lot of changes of the gait speed altering before the obstacle, were single tasking, in those they are cognitive normal versus those with MCI. MCI here is gray, cognitive normal is dark gray. While dual tasking, those with MCI, mild cognitive impairment, they increase and they decrease the speed a lot. So they couldn't manage very well the speed. And the same with the variability. In fact, they didn't show this acceleration that you should see when going to an obstacle. It's in the people with MCI, they couldn't change or decelerate correctly. So posing them at higher risk of falls. So there is connotations about the speed before negotiating the obstacle and the variability, in where those with cognitive impairment, they did worst compared with this cognitive normal. So very interesting experiment for Federico Faria my postdoctoral fellow. He later on tried to map those associations, and he found that those in longitudinal follow-up up to 7 years in the study, including more than 100 people with cognitive impairment, that those that show a decline in gait speed have more fault, but also more problems in rhythmic domains related with high cortex control, related to the control of the prefrontal cortex and the parietal cortex. And the same for variability. Other domains were not involved. So he speculated in this paper that high cognitive domains associated with rhythmicity are important for the automatic control, but those high cortex domains associated with no rhythmicity, those related more with the gait speed, with the variability that depends more on the cortex, are more related to fall and associated with future falls. When he looked which are the brain areas, in this analysis we have some trends, but the only positive area was atrophy in the left hippocampus. It makes sense because those people, the majority have MCI, right? Mild cognitive impairment, which is a memory issue in general, a single domain, was associated with problems in the left hippocampus in these volumetric studies in the imaging. Other of my fellows at the moment, Dr. Jonathan Sneer, he was more focused on white matter. He wants to say, okay, those they have more falls or gait variability or problem with dual tasking, are those having more white matter disease? And he was looking because in general, our study was done in people with normal cognition or just mild MCI. There were not a lot of vascular changes. He was looking for early changes, particularly the integrity of the pathway, the white matter integrity. And he found in those participants that those that we have worse white matter integrity, particularly in the corpus callosum, they have more, they develop more gait impairment falls. And that was quite more marked for those that couldn't perform very well the dual tasking. Those participants have more effect. Look at this tractography here. All this impairment and lack of integrity in the white matter, particularly in the callosum, in those people that couldn't do very well the dual tasking. When he went for the box cells, he found very, very well across the callosum, the corpus callosum, how the low integrity, particularly in dominant hemisphere, the majority of people were right-handed for the left one, was associated with falls in the sample, but also with gait disturbances, slowing gait. So he postulated that poor white matter integrity in the corpus callosum, particularly as a proxy of white matter disease, they have yet, he found was a predictor of falls, but also fall incidence after 3 years of follow-up. So it seemed there is a relation how this white matter regulate gait and how this predicts falls. We don't know it's just directly the white matter generating changes that increase the risk of fall, or it's mediated by gait performance. Anyways, I think that gives us very good insight. There is some structural changes in some areas of the brain that are important for cognition and gait that may explain this neurobiology of the falls. But how this cognition and executive process that in general relies in the prefrontal area affect gait as posture before fall, before the obstacle negotiation, or will have a perturbation? Well, the typical model of perturbation is that in general, when we suffer a perturbation, we have some anticipatory postural adjustment, right? And there is two main strategies, the trunk mobility and the ankle hip strategy. So if our center of gravity is displaced because someone pushes us or we get a little unstable, the first way to cope with that is moving the ankle. So we try to displace our center of gravity in the middle of our base of support, and that perturbation is important, and we cannot manage that. We do the hip strategy. We move our posture towards or laterally through the hips in order to maintain our body and center of gravity under this base of support. However, that is not enough. we need to use, or automatically we use other strategies, like the stepping strategy. We're going to fall, we do one step. We increase one step in order to avoid falling. For example, a cane can be seen as an extra step because they give you an extra leg. That's other strategy. Of course, if we cannot avoid the fall for the stepping strategy and we're going to fall because we do the stepping, but for we don't have the strength in our quadriceps to support our body, and our displacement of the center of gravity is much beyond of the base of support, we have just risk reaction. We try to grab, a hand with handrail just to don't fall, or we use later on we're falling some protective defense mechanism or protective reaction. We put our hand in order to avoid the fall, and perhaps that's the reason we suffer a lot with wrist fractures or putacolis fracture. So these are all the strategies that biomechanically we try to generate when we have some perturbation, and we try to keep our center of gravity, our center of gravity under a base of support. Of course, for all those strategies, it's very important the sensory inputs, because we need to hear and to watch where we place our foot and so on. And it's very important to have very flexible joints, muscle weakness, is other condition that may affect that, Parkinson may affect that. So all those are chronic conditions because you have the sensory input chronically, you have the muscle weakness is not acute in general. So are all cognition that affect all those reflexes, you can imagine. However, we do know that executive function attention is very important for real time for those strategies. Because any of those strategies, if you place your foot few centimeters incorrectly, or you place it in those strategies few milliseconds after or before we need to do it, that may be the difference between falling and not falling. So all these strategies, all these anticipatory postural adjustments rely a lot in processing speed, executive function, and attention. So when you have deficit in these, may affect those strategies, and it will affect how you try to avoid an obstacle, how you want to try to avoid a trip, or how you are going to not have very good reflexes when you need to increase your base of support because you have an external perturbance and you will fall. So I try to make the case that cognition is very important for falls, not only in those with cognitive impairment, but also in those labeled as cognitive normal. So what about if we treat cognition, if we try to improve cognition, if we purposely target cognition to improve mobility and falls? Can we reduce falls? Well, I will try to review the evidence a little with you. And you can go to this paper that's open access, in where with my colleague, Professor Marquez Pichi, will review this. But in general, in the literature, all the current intervention for gait, balance, and falls, I think we can stratify in two big domains. No pharmacological interventions, which include exercise, cognitive training, and so on, and pharmacological intervention, because they have been tried some medications for this. In no pharmacological interventions, this is a busy slide, but just to show you, there is several interventions about cognitive training, dual task training, combined exercise cognitive training. Results are mixed. Some results are positive, but all in general, the sample sizes are very small in the studies. In fact, I will say one of the seminal studies have been led by Dr. Joy Verghese, who compared sessions of cognitive training in a very small sample, 10 people received the intervention, 10 received the control. And he found that the computerized training, so all the people that put in a computer to improve cognition, they fall less than those that have usual care. And he replicated this with a larger sample, and he published in the journal Neurology, but the original paper was in this small sample size. And the same for some groups like Karen Lee or Louis Verret, who are a colleague of me working here in Canada, they're based in Montreal, in where they found that also computerized dual task training in order to improve attention and switching performance has like a transfer effect, improve balance, maybe lateral, maybe peak balance. So there is some evidence that may improve at least surrogate marker of falls, improving gait and balance. And those cognitive trainings in general are related to dual taskings and where you switch attention very quickly and you improve the executive function. Concerning the pharmacological intervention, there is also few studies testing amphetamines for the improvement, particularly in the attention, the methylphenylidipine as an amphetamines, and they found positive results. The issue is those medications are very complicated to give in older people, right? And other people have tried, like in my group, have tried content enhancers. So those medications that stimulate cholinergic neurotransmission, and we found also some positive results in MCI and Alzheimer's, and mainly the most important results are coming in Parkinson's disease. But just to show you some results in our study, we used donepezil in those people with MCI that didn't have indication for donepezil. That was in a small study, proof of principle randomized controlled trial, 30 people in each room, in each group, and we found that donepezil after intervention improves gait performance, particularly gait performance with dual tasking. So those receiving the medication, they can walk and talk better, that don't receive the medications. And you can see here how those receiving the medications in green reduce the cost, they have less cost, so the reduction in dual tasking was 10%, while those getting the placebo, they got worse after the intervention. Importantly, when we look for actual falls, which is not the primary outcome in the study because of proof of principle, we found those taking, donepezil, they reduce fall. Again, results are not significant, but interesting, I will say, proof of principle concerning about the concept that if we improve some aspect of cognition, like a cholinergic neurotransmission, we may reduce falls. Doesn't mean we need to get donepezil people now to reduce falls today. I will review that because there is a caution here. Those are small studies and can be a publication bias, but probably negative studies were not published, right? So again, but I think as a proof of principle is coming back to this concept that Bernard Isaac postulated about falls as a result of brain failure, that perhaps we can use some medication to stimulate some area of cognition to reduce fall. And this is an area for future research for sure. So what we do when one study is not enough, those studies are very small, can be publication bias. We try to do a meta-analysis. We try to look for all those studies and to make a bigger sample size. And a group in McMaster performed a systematic review and meta-analysis that was recently published in BMZ Geriatrics in 2021, in where they it was led by Racy, but also my colleague Susan Moore Hunter is part of this paper, in where they review the evidence in the community when we target older people with mild to moderate cognitive impairment, so MCI and mild dementia. And they look for falls as an outcome, but also proxy of falls, or surrogates, or intermediate outcomes like fear of falling or perceived fear of falling, balance or equilibrium, and also gait speed or the time up and go, the tag. And they found that the evidence that use fall prevention intervention in the community to prevent falls is very low, but there is very good evidence to moderate, to improve those surrogate markers. And mainly in those meta-analyses for the fear of falling or perceived risk of falls, the meta-analysis shows a pull effect, quite interesting, a pull effect of 0.73. So perhaps, a 27% improvement in that perception of fear of falling while trying to do those interventions or multi-domain interventions. And I will go to the intervention later on, but the majority of the interventions include some kind of exercises and dual task exercises, sometimes include diet. They include all the multi-domain interventions in that. For balance, they found the same. In fact, the pull effect is better. The pull effect is almost 40%, 34%. And for gait speed, they found that was 74%. And you can see the confidence intervals are all significant. And the same for the tag. So there is some evidence for those systematic reviews that we review here that combining multi-domain interventions and all the time including exercise participation may have effect, moderate evidence in gait, balance, fear of falling, and low evidence in some studies may prevent fall or not. So it still is a challenge. But other systematic review meta-analysis, when they look just for pure exercises in this systematic review, they found that there is a trend, and that was published in 2021 also by the Nature and Aging, for combining physical exercises to prevent falls in cognitive impairment, particularly with mild cognitive problems or mild dementia. And I think when they include people with moderate or severe dementia, that's the reason the confidence interval across the one, as you can see in this forest plot. So emerging evidence, particularly in those that have mild to moderate dementia, that if we use combined intervention, multifactorial, particularly to be exercise part of the component, you may have an effect. You may be a difference. So that's a positive change since the classical meta-analysis done by Oliver in 2007, in where new evidence show not only exercise are feasible to do in MCI or mild dementia, but also may have an effect. So what are the conclusions of this talk? Well, I'm going to analyze first, what is the level of evidence? And later, what can you do practically for your patient with cognitive impairment to decrease the risk of falls? I would say that, unfortunately, the global effect of fall prevention in this population, cognitive impairment, still remains a little elusive. However, exercise interventions are effective at improving fall risk factors, fall rates in people in the community, cognitive impairment in the community, some people with MCI and mild dementia, and some in nursing homes, but not in the very impaired one, not in the very impaired one. And high quality studies with longer follow-up may be needed to confirm all these trends and interesting findings we found. But the second level, what you can do for your patient? Well, first, as a recommendation, and there's expert opinions, that we try to make the case how cognition affects fall risk, also in those labeled as cognitive normal. So we believe cognitive evaluation should be part of the comprehensive fall risk assessment for all older adults, not only for those labeled with cognitive impairment. Clinicians, particularly if you want to treat those with cognitive impairment, should involve the patient and the caregiver in planning fall prevention, because there is evidence showing that those interventions, the fidelity to the intervention and the results are better if the caregiver is involved, but also if the patient like to do the exercise. When you try to provide an exercise treatment, you need to speak with your patient, which is the more feasible to do, what is the exercise they want to do. And when you get good fidelity, you get good results. So there is evidence about that caregivers and patients should be involved in the planning of the strategies to prevent falls in the cognitive impairment. As I said before, exercises interventions are feasible and reduce fall risk falls, so should be the cornerstone of the treatment. Adding other interventions may have additional effects according to some meta-analysis. But also, in general, we should do general actions that could help to preserve cognition and prevent falls. So we need to review the medication. We do know sedatives, benzodiazepines, and psychopharma medication reduce processing speed, reduce switching capacity, make dual tasking worse, so increase risk of falling. We should provide a strength, balance, and cognitive training exercise when available, if your system have that available. We should correct vision and hearing problems, because the sensory inputs are very important for all those strategies we review in the neurobiology of falls. We should correct vitamin D deficiency. It seems that hypersupplementation of vitamin D doesn't have an effect, but if you have deficiency, yes. If we give you vitamin D, we can improve your risk of falls if you have vitamin D deficiency. So we need to be sure our patients are vitamin D repleted. And we should check home and remove hazard for any safe walking in order to avoid these problems that happen with aging and cognitive impairment with obstacle negotiation that we review. So as a final summary, I would like to convey, and I hope I convince you with this evidence and this talk, that cognitive deficits exacerbate fall risk in everyone, even in those with normal cognition, that the fall risk screening should include cognitive process evaluation, particular attention, inhibition, executive function. That cognitive impaired treatments in the population to prevent falls should include physical exercise, focusing lower limb and strength and balance. And there is some evidence that cognitive training may improve on this, but it's a complementary approach. And there is some publication bias, small studies, something that still needs to be fully proven in larger trials. If you want to learn more, we have a book that we edited with Professor Richard Camiccioli about falls and cognition. Also, we are leading the 4 words guideline for prevention and manage older adults. You can go to our website to learn more about this, but we hope our guidance and recommendation will be presented in September 30, 2022, during the European Union Geriatric Medicine Conference. So we wait for you there and in order to share our results and recommendations. And just to finish, I will give you my email. I'm thanking all the people in my laboratory, my co-investigators, and the agencies that pay the bill for my research. And I'm open for any of your questions. Thank you very much.
Thank you very much, Manuel, Professor Montero Dasso, for your excellent presentation. It's really a cornerstone. And we are beginning with the Q&A sessions. We have 8-10 minutes for some questions. See, we received one of them. That is congratulations to you and for me for the conference and for Professor Kaplan. Congrats in this way. This DL Maria is a colleague from our old hospital. Asked, could the evaluation of the impact of dual or multitasking in walking help us to individualize the recommendations to prevent falls? Is training to improve multitasking ability in a safe environment possible or useful?
Well, thank you very much for all the comments. We are honored that we are able to name this lecture in honor to the Professor Roberto Kaplan. Very nice to see you, Maria. Thank you for your question. Very interesting question. Dual task gait, as you know, is an area close to me because based on my research, dual task gait as a predictor of falls in some populations, it seems is better than single gait. In other populations, it's the same. Some systematic reviews showed that dual task gait doesn't add any extra information to single task. Although a new systematic review where they compare studies using both tests, the single test and the dual task gait, there is some evidence that show that, but it still is not very categorical. Concerning dual task training and how it can help in your individual patient, I will say, if I see in my own patient that the dual task gait is very, very impaired, I do know that patient has some problems in the cognitive motor interface and a higher risk of falls. When we try to retrain that, the studies showing positive results are very small. They're very small studies. There is a couple of randomized controlled trials done for the group of Professor Schweck in Germany showing positive results. In general, they work with combined with exercises. So when you provide physical exercises combined with kind of dual task training, it seems may prevent fall, particularly sequentially. Or in studies, when they do concurrent and concomitant, the results are not as good. One hypothesis is because the patient gets distracted, cannot focus and do the physical exercise very well because trying to do dual tasking. But again, there is some emerging evidence that sequential dual task training may prevent falls in some people with cognitive impairment. Still small studies, we need larger randomized controlled trials. Interestingly, in people with Parkinson's disease, dual task training with virtual reality, there is larger studies from the group of Alan Mirman involving more than 100 participants in each arm, showing that that is feasible and may reduce falls. So again, small studies in general population may be an impact in those that have the cognitive motor interface impaired. Larger studies with stronger evidence in Parkinson's disease.
Okay. Thank you, Manuel. Another question from Dr. Luis Mackern is, if functional exercises from the age of 15 in advance should be required or work for all persons in general?
Functional exercises.
Yes.
Well, depends how we define functional exercises. So if functional exercises, goal-oriented exercises, in where you do exercise with a goal, yes, there is some evidence, particularly the group of Joe Berghisi in New York, is showing goal-oriented exercises may improve surrogate marker of falls, like gait speed or gait variability. I don't know any goal-oriented exercises that reduce falls. In general, for example, we do know that exercises involving balance displacement or involving strength in the lower limbs, following, for example, the Otago protocol, the classical Otago protocol, are very useful to prevent falls in the community. And also in some patients with mild to moderate cognitive impairment. With severe cognitive impairment, it's more challenging, it's not working very well. But all physical exercises that involve balance retraining, but also strength in the lower limbs, prevent falls in the community, and mild cognitive impairment and mild dementia. Goal-oriented exercise is that functional exercise, the question. There is a study showing the improved surrogate marker of falls, like a gait speed, but I don't know any studies having falls as a very hard outcome.
Okay, we have not much time, just only 30 seconds. And another question by Dr. Mayra Villalba is, how can we prescribe exercise? It's just similar to this. But if you have 30 seconds.
We used to say that prescribed exercises is like a prescribed antibiotics, right? We don't prescribe antibiotics. We prescribe a specific antibiotic, ciprofloxacin, a specific dose, and so on. Exercise is the same, and there is several barriers for exercise, because sometimes you can prescribe the exercise, but the patient or the participant may not do it. So there is several stages. In general, exercise that prevent falls are those, as I said before, that involve balance retraining or displacement of the center of gravity, or those that involve strength training of the lower limbs. Walking is an excellent exercise, not necessarily will prevent falls. Upper limb exercises or going to do strength training in upper limbs, not necessarily will predict falls. So what necessarily prevent falls are those involved balance, center of gravity displacement, and lower limbs resistance training. In the World Fall Guidelines, if you go to our website, I'm trying to put resources and toolkits, not only how to provide exercises, but mainly follow Tai Chi or the Otago protocol, but also which are the barriers and how you can personalize the exercise. Because something we do know is that when you prescribe the exercises in your population and you involve the patient, you involve the participant with the exercise, and you speak about the preferences and you address the barriers, we have better adherence to the exercises and better outcomes. And that is part also, our new guidelines is presenting that with some toolkits and resources that is going to be in our website after September 30th. I hope I respond to your question.
Okay, we have no more time. Thank you very much again, Manuel. It's an excellent conference. And of course, one of the cornerstones of the geriatric medicine in the future is to understanding falls mechanism and association. Thank you very much.
Thank you for having me, guys.